Good morning, and thanks for joining us. I'm Barb Wilson, your moderator for part 3 of the Cancer Survivorship Series, Rise and Shine, Being Your Best After Cancer Treatment. I would like to introduce Dr. Bruce Gould, who serves as Medical Director of the Infusion Services at Wellstar Health System, and Dr. Gould is also our medical lead for the Wellstar Survivorship Program.
Thank you, Barb, and welcome to the third part of the survivorship seminar. So, as I said, all you out there who've been through chemotherapy and have fought cancer and beat it, congratulations. So I'm going to talk a little bit about living your best life. First of all, one of the first questions I get asked after a patient completes chemotherapy and they're in remission, they say, "Okay, doc, what do I do now?" I tell them 3 things. One is keep your follow-up appointments with me because I need to monitor you for recurrence of your primary cancer. Secondly, I say, don't forget to take care of the rest of your body, which is what I'm going to talk about today. And then thirdly, go out there and live your best life, and help you do that, make sure you do parts 1 and 2. So what does it mean to look out after the rest of your body? Obviously, the number one thing that's known to cause cancer is tobacco. Not only does it cause lung cancer, but it also causes throat cancers, esophageal cancer, and bladder cancer, in addition to heart disease. Obviously, it's important to maintain a healthy weight. It's well known that obese people have a higher incidence of cancer than people who are ideal weight. Next thing is to keep moving and eat plenty of fruits and vegetables. All this works hand in hand to control weight and to control the lipids in your body. The next thing is to limit the amount of alcohol intake. The next is to protect your skin. Skin cancers are one of the most common cancers. They're easily preventable by wearing long sleeves and long pants to directly block the sun or to use sunscreens. It's important to know your family history and your risks, and that can be discussed with your oncologist. And then the final part of maintaining good health is to get regular checkups and cancer screenings. And I'm going to talk about the cancer screenings next. So for breast cancer, it's recommended that women by the age of 45, they should start getting regular mammograms. A lot of women are rightly concerned about their breast cancer risks and may start sooner at age 40. Before age 40, the mammograms are not so good because of the dense breasts make trying to find cancers the equivalent of trying to see a polar bear in a snowstorm. After age 55, on the other end of the age spectrum, the mammograms can be done every other year. Obviously, it's important for women to do regular self-breast examinations so they know how their breasts feel and what's normal for them. In addition, for good women's health, it's important that they be screened for cervical cancer. Cervical cancer is a disease of younger and middle-aged women. It's caused by the HPV virus, and it's recommended that the HPV viral screening be done every 5 years. If that's not available in your community, then a pap smear needs to be done every 3 years. Colorectal cancer is a disease that affects both men and women. The screening guidelines used to be age 50. They've been dropped to age 45 because of the number of younger patients that we're now seeing with this disease. The thing about colorectal cancer is, one, it's a disease that tends to hide because it's obviously deep in the bowels where it's not readily felt. And secondly, a lot of these cancers can be prevented if the polyp which is a precancer, is removed. So the best way to treat a cancer is to get rid of it before it develops. And by removing polyps, that's the way to do it. Typically, it's recommended that if the first screening test, which is a colonoscopy, is negative, then it can be repeated every 10 years. If there's polyps or precancers found, then there's going to be more frequent follow-up. It's recommended that for people in good health that colon cancer screening be done through age 85. For people in less good health, it can be stopped at age 75. Lung cancer, this is applicable to smokers. So lung cancer screening is done through low dose radiation CT scans. These are specialized CT scans looking for lung cancers and nodules. And they're applicable for people who are aged 50 to 80 who currently smoke or quit in the past 15 years and have a history of smoking at least 20 pack years. That's calculated by taking the number of packs per cigarette smoked per day times the number of years smoked. And I can tell you that WellStar is probably one of the leaders in lung cancer screening, thanks to the efforts of Dr. Bill Mayfield, our thoracic surgeon. Prostate cancer screening is a little more controversial. It depends on who you ask, depends on what kind of answer you get. The American Cancer Society, which is the recommendations I'm talking about today, actually does not recommend regular PSAs or regular screening. However, urologists and internists and cancer doctors like me do advise yearly PSAs and digital examinations of the prostate. So that's an individual choice to discuss with your doctor. It's controversial in terms of what the screening recommendations are for prostate cancer. So I'd like to move on to talking about the benefits of a therapy that's free, and that's walking. As advised for healthy lifestyle, that one walk at least 30 minutes a day. And there are many benefits to this. It boosts your heart health. It boosts your muscle and strength and bone strength. And the way it does it is that your body needs a certain amount of stress, if you will, and I don't mean psychological stress, but physical stress, in order to maintain muscle development or bone development or the strength of the heart and heartbeat. So exercise is a good way of doing that. It doesn't have to be a brisk walk. And I would also throw in there maybe doing some light weights as well will help, again, build muscle and bone strength because of the because of the stress put on the muscles and bones by the light weights. Walking also improves the moods, cuts down diabetic risk by lowering the weight, and then it may be beneficial in terms of cancer prevention. Now, I would be remiss in not saying something about COVID. It's best to get vaccinated so you can live your best life COVID-free. And this is a graphic from the WellStar website in which it makes the point that over 90% of the patients that are hospitalized with COVID are unvaccinated versus the 10 that have been vaccinated. And more importantly, 92% of the cases in the hospital or in the ICU, I mean, are unvaccinated versus 8% that are vaccinated. I can tell you as a doctor that spends a lot of time in the hospital, I've yet to see a patient in the hospital with complications from the vaccine. Yes, there are people who get flu-like symptoms for a day or two after the vaccine, but other than that, as far as we know, there's no serious side effects to the vaccine. But yet, it's clear that a lot of serious complications are associated with the COVID infection itself. In addition, I also recommend regular vaccinations with the flu shot and or pneumonia shots if that's appropriate for your age. So this is a quick overview on how to live your best life from a medical perspective. So I'm going to turn it back over to Barb Wilson to begin the seminar. Thank you for your attention.
Thank you, Dr. Gould. I'm going to be your first speaker for today on chemotherapy and immunotherapy impact on survivors. We also have several other speakers, and they'll be introduced right before their session. I would like to address, begin this session by talking about the definition of systemic therapy. This is treatment that uses substances that travel through the bloodstream and reach and affect cells all over the body. So the medication could be administered intravenously, by injection, or the person could take pills and it would still travel to all parts of their body. When we talk about when these systemic side effects occur, we bucket them into short-term side effects, which can happen during the treatment or immediately following the treatment, usually between treatments. Long-term side effects can persist months or years after the treatment is completed. And if you look at the list of things that it can impact there, when we talk about lungs, nerves, heart problems, many of those things appear on the list for late effects. Late effects are caused the same way that the long-term side effects are, but maybe they're not present during or following treatment, but they manifest themselves months or years after the person has completed treatment. Not everyone who has cancer treatment experiences long-term or late effects, and different chemotherapy drugs can cause different late effects. If you didn't take a chemotherapy drug that causes damage for the nervous system, for example, then your risk for developing that particular side effect is limited. And as Dr. Gould reminded us, everyone who has had cancer treatment requires regular medical follow-ups to assess for side effects, new conditions, as well as cancer recurrence. So what we're going to focus on today as examples are 4 of the systemic side effects: lung problems, nerve problems, heart problems, and bone problems. I'll begin with the lung problems, sometimes referred to as pulmonary side effects. These may be caused by the person taking immunotherapy or chemotherapy that result in damage to the lung. Some of these symptoms may not be noticed for years after the treatment has been completed. For example, a drug that we use for chemotherapy is called bleomycin, and this causes a side effect that is pulmonary fibrosis, where the lungs get stiff and they don't move in and out very freely. They're less compliance in there, where they can move back and forth, and the person experiences more difficulty getting a deep breath and sometimes feels short of breath either when they're exerting themselves, and as the conditions worsens, they can even feel short of breath when they're resting. It just becomes more and more difficult to get a deep breath. On the other hand, immunotherapy, for instance, Vectibix, can also cause that same side effect, pulmonary fibrosis, where the lungs get stiff. Or if it's another drug like Yervoy or Tecentriq, it can cause a lung side effect we address as pneumonitis. And the definition of this is an inflammation of the lung tissue. The symptoms that the person would experience or would bring to the attention of their physician is that they're feeling short of breath. They've noticed that there's wheezing when they're breathing. They may have a fever, a dry cough, some congestion, which would lead to a productive cough, and a sense of feeling more tired than usual, doing less activity. If you have symptoms of lung damage, you will have tests to see whether they are due to the cancer in the lungs or the late effects of treatment. And there are some things that are done while the person is getting these drugs. They're being evaluated first before they begin the drugs to see if they have underlying lung disease. And then during the treatments, there are recommendations for doses. For instance, bleomycin has a lifetime dose limit, how much the person should receive over their lifetime before we would anticipate a higher risk for lung damage. And the other thing is, if they do start to have lung problems during treatment, they may pause the treatment and wait for the lungs to heal and recover. Or if they're not recovering or not recovering quickly, they may discontinue the medication because the harm is greater than the benefit. Oxygen therapy can treat breathing problems, but only if your oxygen level registers low. Everyone who feels short of breath or is experiencing difficulty with breathing is not eligible for oxygen. The levels have to register as low. Dr. Gould reminded us about the benefits of losing weight or keeping a healthy weight and not burdening the respiratory and cardiac system. Exercise can train our lungs to endure more activity and give us resilience. Not smoking, even using vaping inhalation, or drugs that are not prescribed by your doctor, those can all be very harmful to the lungs. Taking medications that are prescribed, if you're supposed to take steroids or breathing medications or inhalers, only using them the right way will give you the full benefit. Pneumonitis, the side effect caused by immunotherapy, is treated with steroids. It's not treated with antibiotics. And if you do take steroid pills for lung problems, it is important to maintain a healthy weight because weight gain is a very common side effect of taking steroids. The next side effect I wanted to talk about was peripheral neuropathy. And the definition of this is damage to the nerves in the peripheral part of the body, the ones farthest away from our spinal cord, like the hands and feet or the fingers and toes more particularly. The person who has peripheral neuropathy would describe it as numbness, tingling, or a painful sensation. Examples of systemic therapy that can be associated with peripheral neuropathies are groups of drugs. The platinum drugs like oxaliplatin, cisplatin, carboplatin can cause peripheral neuropathies, but they're not all the same. And peripheral neuropathy isn't the same. You may know of people who have diabetes who have peripheral neuropathy, or alcohol excess intake can lead to neuropathy. But the symptoms from the platinum agents, if it's oxaliplatin, even after the treatment has been stopped, the symptoms may worsen for several months, and the person may notice intensification of the pain, tingling, and numbness. The taxanes are another group of drugs, and they tend to affect the feet or the toes more than the hands. And with those, the symptoms will usually subside and resolve, but the research shows it takes anywhere from 2 months for some people up to 22 months for other people for the taxane peripheral neuropathy to resolve. Another drug, thalidomide, which is an immunomodulator, also has a side effect of peripheral neuropathies. At least 50% of the patients who take that drug develop some degree of peripheral neuropathy, but of that, only 10% experience the severe type, where they would need to have medication or stop the treatment for that. The management is that first of all, there is no evidence-based treatment, which means a proven way to prevent chemotherapy-induced peripheral neuropathy. There are some theory-based methods that say if the chemotherapy doesn't get to the fingers and toes, it may not cause that side effect. So we try restricting circulation to the fingers and toes by putting ice soaks on them, or wearing tight cuffs to restrict circulation. But that is not evidence-based, it's just being tried. ASCO, which was the American Society for Clinical Oncology, our physician specialist, do not recommend the use of dietary supplements or any other medication or supplement to prevent peripheral neuropathy caused by chemo. There's no evidence to say that we can do that. So the best thing that we can do is assess people's baseline nerve function. Do they have any damage to their peripheral nerves? And then monitor before each treatment to see if it's safe to continue with it. If it's mild side effect, we may watch it, but if it becomes debilitating where they're unable to feel or the pain becomes more intense that they're requiring medication, we may stop the agent that's causing the neuropathy and then determine when it's safe to resume it again, or again, whether the harm is going to be more than the benefits of that treatment. There are some medications that are evidence-based that will treat the pain for neuropathy, but they don't actually treat the neuropathy itself. And one of those is Cymbalta. You may be familiar with that drug. The next side effect is heart disease, and that can be a late effect of chemotherapy. Anti-cancer drugs that tend to cause heart problems include sometimes immunotherapy. An example I'm using here is Herceptin or trastuzumab, and other ones, particularly a group of drugs that we call the anthracyclines. Some of you may have had these. They tend to be orange or red in color, depending on if they're in a syringe or in a bag. And I always associate that color with the heart and thinking about the person's heart health. The heart disease that can be caused by these agents is congestive heart failure, known as CHF, and it's other people in our society get congestive heart failure, but the cause is different. This one is directly related to administration of one of those anthracyclines and is a weakening of the heart muscle, and the person may experience shortness of breath, dizziness, and swelling of the hands or feet. Another side effect which occurs is coronary artery disease, when the small blood vessels that supply oxygen to the heart become narrow and they can't perfuse the heart tissue anymore. So the person would experience chest pain in addition to shortness of breath. The way to manage these cardiac late effects, if they show up after the treatment, is, as Dr. Gould mentioned, make sure you keep your appointments where the physicians know what drugs you received and what side effects to be watching for. And make sure that you're doing all the things that he encouraged you to do. Eat a heart healthy diet, lose weight if you're overweight, don't smoke, don't start smoking, quit smoking, avoid smoking, even secondhand smoke, to reduce your damage to your heart and lungs, and get enough rest. Being stressed out, being tired is not good for heart health, and it's not good for your emotional health. And then to take the medicines that are prescribed by your doctor, and most of all, keep your follow-up appointments. So it's that triad of avoid tobacco, be more active, and choose good nutrition. The last side effect that I wanted to talk about that can happen with our some of our systemic therapy is osteoporosis, which is thinning of the bones. And as you may have recognized already, is that some of these things like lung damage, heart damage, and thinning of the bone or osteoporosis happens in the general population too. And so that's why you need to go see your doctor to determine whether it's a normal aging process. We're all living longer, and especially people who have been diagnosed with cancer may live a very long time. And so getting older predisposes you to this, as well as having cancer and some of the side effects from treatment. So immunotherapy may cause problems in the joints or muscles, and those are known as rheumatologic issues. And people who are not physically active will have a higher risk for developing that. So cancer survivors can lower that risk of osteoporosis by doing the things that Dr. Gould and I have already mentioned: being physically active, avoiding tobacco and alcohol. And the reason that he was talking about doing the weight bearing and walking is that it pushes the calcium back into the bones and makes them stronger. And you have less of that thinning of the bones, which makes you at lower risk for getting a fracture related to that or experiencing the discomfort and pain. These are some of the references that used to put the material together for that presentation, and also some resources if you want to find out more information about any of those things. And if you or someone else is trying to quit smoking, there are a number of ways to do it: cold turkey, using some of the pharmaceutical products to do it, or just getting some coaching. And there's a really nice video that we have available that says, if you're thinking about it, let's help you think some more about it, and just talking about the benefits of it. So there are some resources here for you. I'd like to turn the next presentation over to Terry Wirt. Terry is one of our radiation nurses at Paulding Radiation, and I'm proud to also announce that she has been our 2021 Crump Excellence in Oncology Nursing Award winner, and that is given to someone as a scholarship who has exceeded and gone above and beyond in their role as an oncology nurse. So I'll turn it over to Terry, who will address some of the long-term side effects of radiation therapy.
Thank you, Barb. First, I just want to go over kind of what radiation therapy does. It plays a significant role in the cure and control of cancer, and it's also used for palliative purposes to relieve pain. has the potential for early and late side effects. So it's very important to monitor not just during and shortly after, but even long-term, the patient to make sure they've got the best possible outcome. And if they are having side effects, that they're being treated appropriately. Today, I want to touch on not just the early and late side effects and kind of what to look out for, but how nursing and the coordination of care between the different disciplines helps the patient to deal with these side effects. Radiation therapy is an ionizing process that carefully delivers a determined dose to a precise volume in a variety of ways. Most commonly, it's external beam radiation, which is what we're going to talk about today. And ionizing really just means it's a disruption of the cell structure. So it damages the DNA of both cancerous cells and normal cells, limiting their ability to divide and replicate. Normal cells can repair the tissue, whereas cancer cells cannot. Most commonly, and every diagnosis is a little bit different, but patients typically receive a daily dose or a fraction of radiation 5 days a week, typically over several weeks. Daily and cumulative doses are formulated based on the particular diagnosis, the site, the pathology, and the purpose of the treatment, whether it's for cure or control or for palliative purposes. Side effects vary by treatment location, daily dose. Some patients are doing concurrent chemotherapy at the same time as they're doing radiation. So they may experience some decline in energy or nausea, whatever, from the chemotherapy. And then radiation is kind of exacerbating that because they might be having some early side effects from that as well. And also patients' predispositions, to different side effects can affect that. So we'll just start at the top. Brain radiation for early side effects, and this fatigue pretty much covers just about every diagnosis that we treat. Fatigue is just a normal, when you're doing it for several weeks, it's kind of a generally common side effect. Hair loss, nausea and vomiting. Vomiting, maybe depending on what part of the brain is being treated. Headache and skin changes, redness, dryness, irritation, just like if you were getting a sunburn. As far as the headache, though, I want to make a point. A lot of patients think, oh, well, I'm just going to take medicine. I'm going to take Advil or Tylenol or prescribed narcotics from the physician. But for brain radiation, if you're having headaches, it's typically you need steroids. So that's typically what the doctor's going to prescribe. And a lot of patients don't, they might be a little hesitant because sometimes they make you jumpy or, inhibit your sleep a little bit, but that's what really treats the headache. And for skin, we just use really topical things. You can't totally prevent skin irritation from radiation therapy, but when you come to radiation, any of you that have had radiation know we don't want you to have any lotions or creams or anything on your skin, especially the area that's being treated during treatment, but then afterwards, we'll recommend different things. For possible late side effects, not every single patient has this, so that's important to know. But just to give you an idea of what maybe to keep in the back of your mind to look out for. So short-term memory loss, verbal memory, spatial awareness, attention, and problem solving. That can be a late-term side effect. And depending on which trial study you look at, they'll have different timeframes that those might occur. So it's really important to talk to your doctor about that if you're having any of those symptoms. Brain necrosis is pretty rare. But a patient, if they were having that, they might have a new onset of seizures. They might have, intractable headaches that just don't go away, focal deficits, so that specific areas of the body are having an issue. So you notice something in your right arm, or the left side of your face, but not, the other, that type of thing. And it's treated with steroids, just like the headache for brain radiation. Hearing loss can also be a late-term side effect, and it causes inflammation and pain. It can cause some earwax buildup, so that might just exacerbate the hearing loss. And once you get that taken care of, it might not be as bad. But they say anywhere from 3 months all the way up to, a decade or more after treatment that you might notice that. Head and neck. Head and neck is really the most challenging diagnosis that we treat in radiation, because there's so many things involved, and a lot of early intervention is really, really important. The early side effects, most common, are taste changes, dry mouth, difficulty swallowing. And the difficulty swallowing isn't that there's a problem with your esophagus necessarily, but radiation thickens the saliva. So patients might feel like they're swallowing pills or food, and it's just kind of getting stuck partway down, and it's because of the radiation. Jaw stiffness, hair loss. If our male patients may have beards, mustache, that it might cause that. Fatigue, again, because this is a diagnosis that gets treated for several weeks. Nausea, tooth decay. The important thing about head and neck is that we get pre-treatment dental clearance to make sure that your teeth are healthy, your gums are healthy. Radiation to the head and neck, even thyroid, can cause later loosening of your teeth, and that can, just be a breeding ground for infection. We typically refer head and neck patients pretty early to speech therapy, just to make sure they're not having any swallowing difficulties. They may be referred to surgery for a feeding tube. That does not happen to every single head and neck patient. But if their nutrition is in question and they're already really low on their weight and a little compromised, the doctor might talk about that. We have a dietitian at Paulding that really keeps on top of our head and neck patients. So their daily weights, we're really encouraging them to keep their hydration up, and nutritional supplements like Boost and Ensure, that kind of thing. And for the symptoms like the dry mouth, the taste, I don't know that Magic Mouthwash really helps that, but Magic Mouthwash is a compound rinse, and that really helps keep down the pain in the mouth. If you're getting sores in your mouth from chemo or from radiation, it kind of helps that. And it also coats that whole lining so that you're able to swallow less painfully. Late side effects. Barbara already talked about fibrosis, and this can happen as a result of head and neck. So you can get a thickening or a scarring to that portion of your neck that was treated. And in some cases, it could cause some difficulty with range of motion. So we typically treat that with physical therapy. Hypothyroidism is also a late effect. And some studies say it can happen up to 20% of patients, usually within the first few years after treatment ends. So you just want to continue, make sure you're getting those things kind of checked with your doctor. If you're going to a primary care, that may not be on the forefront of their mind that, oh, you had, head and neck radiation 10 years ago. So you want to make sure your thyroid is monitored and screened. Hearing loss, dental decay, especially if you didn't take really good care of your teeth beforehand. We really encourage head and neck patients to be really vigilant about their dental care after treatment. Dry mouth, which can be permanent, not always, but we usually recommend increased hydration and then over-the-counter things like biotin, and there's a rinse, chlorhexidine, that we use in the hospital setting a lot, and that just helps prevent infection because your salivary glands aren't really working as they used to. So we've got to keep that protected so you don't develop an infection. Change in taste. pretty much all the head and neck patients kind of their taste is affected. It doesn't always return in the same order that it left. So you may, when you get your taste back, you may have bitterness, and everything might taste better if you eat a piece of cake or eggs or what have you. But sometimes you can have a different change. And most often, if I have a patient that complains about that late, a couple of years after treatment, they might say something like, oh, I used to really like chocolate, but now I just don't really like that anymore. It's not very appetizing. So you could have that. Lymphedema, like any area that you get radiated, especially if you've had lymph nodes removed, you can develop that with head and neck. And they send you to physical therapy, manual lymphatic drainage, and WellStar does have lymphedema specialists. So this is what they do every day. So they'll do manual, like massage to drain that lymph system, and also compression bandages. For breast, early side effects, or even during treatment side effects, skin changes such as redness, dryness, irritation, just kind of like a sunburn. Some women might get some swelling. Breast patients typically who are doing external beam are doing it for 5 or 6 weeks. So they'll, usually notice a decline in energy as well. The sore throat is really, if we're treating the supraclavicular area, if it's really high, if that cancer was really high up and we're treating that area, it can cause maybe a little bit of that. Body image disturbance, which probably Lisa will talk about when she goes over surgical stuff. But some women, if you've got really darker skin, might notice not so much that you get redness, but that it just gets really, really dark, and it doesn't always completely return to the same shade as the other side. A possible late side effect is lymphedema. We pre-op, the nurses are really good about doing lymphedema measurements. So they're going to measure both of your arms, 3 different places. And then if you come to us for radiation, we do that as well. And just we keep on top of it. And when we see you every week for, on treatment visits, we're asking, are you noticing any swelling? Are you noticing anything different when you're reaching for a cup in the cabinet? The important thing about that, I think, is just keep that in the back of your mind. The risk increases depending on what kind of lymph node is taken out, if it's taken out at all. And you just want to keep on top of it. So if you notice anything weird, if you notice anything that's different, oh, this feels different, your body, you need to let somebody, know right away, because the earlier we get on it, the better it is. Swelling, edema, esophagitis, the same kind of thing with the sore throat. Depending on what area of the breast we're treating, you can notice some irritation maybe in your esophagus. And so you might have a little burning when you're eating, feels like heartburn. Radiation pneumonitis, which Barb talked about, may develop weeks later, months later. You would notice a fever, cough, shortness of breath, maybe some chest pain. And the first line treatment for that is steroids. Your doctor might also prescribe an inhaler, cough suppressant, decongestant, that sort of thing. At Paulding, we have a prone breastboard, and that is really beneficial just because it helps. You're laying on your stomach for treatment, so the gravity just helps. It's an extra layer of protection to keep everything away from your heart and your lungs, all your vital organs. Those women that are able to use a prone breastboard, we do notice that they don't have the skin changes nearly as much as if you're laying on your back. For lung cancer, early side effects would be cough, shortness of breath. If you're a smoker and you have that already, you've already got a cough that's pretty consistent, you might notice an intensity increase on that. Fatigue, same kind of thing. Lung patients are typically doing chemo the same time they're doing radiation. So they're getting it from both directions. So they might notice, fatigue, skin irritation in that part that we're treating. So redness, dryness is typically what we see. Esophagitis, same kind of thing, as we talked about with head and neck. Possible late side effects could be a pleural effusion or radiation pneumonitis, which we just talked about. So the first line treatment for that is steroids. If you notice after you've finished treatment that you've got a fever, you've got a new cough, shortness of breath, chest pain, you need to let your physician know right away. And the last thing I'm going to talk about is pelvic, and I kind of put those all in the same slide because they share the same side effects. So GYN, prostate, and rectal. For any pelvic radiation, pretty much the most common side effect is diarrhea or constipation. And I will say of the GYN, prostate, and rectal, the prostate guys probably have the least amount of complaints about that. And you may not have it at all, or you may have one or the other, and you take some over-the-counter medicine and then you don't have it again. So it's not always really severe, but it is important to let your doctor know what's going on. Fatigue, prostate patients are not doing systemic chemotherapy. GYN patients typically are, and rectal patients sometimes are doing IV chemotherapy, and sometimes they're doing a pill that they take at the same time as radiation. So they might notice a little more increased sense of fatigue. Skin changes and urinary changes. Burning, urgency, frequency for women, or the prostate guys feeling like you have a UTI, you need to let your doctor know. It might be the radiation, it might be something else. For late effects, and these are just possible, not everybody gets these, but urinary incontinence or retention, and also possibly fecal incontinence. And I mention that because what they found in some studies recently is that people don't want to tell their doctors that they're having fecal incontinence. So if they don't tell you, or if you don't tell them, then they can't really help. So it's really important if your doctor asks if you're having normal bowel movements, and you are having normal bowel movements, but occasionally you have some leakage, you really, really need to let them know. The treatment for that, for urinary incontinence, if it's really severe, depending on what the patient really wants to do and the disruption in their quality of, daily activities, they may recommend surgery, or even prior to that, pelvic floor therapy has had some really good results for men and women. Rectal bleeding can also be a late side effect. And just like hematuria, which is blood in your urine, the radiation affects those, it weakens the small blood vessels. So that's why that can occur. Small blood vessels in the bladder, in the rectum, and so you'll notice blood. Vaginal stenosis is a pretty significant risk for GYN and rectal. So your radiation, if you haven't heard it from your oncologist, your medical oncologist, the radiation oncologist will talk to you about dilators at the end of your treatment, and they'll give you parameters of how long to wait and how often to do it. And the reason for that is radiation can cause scar tissue. So you don't want to fill up that cavity with scar tissue, because that's going to inhibit you getting pap smears and physical exams from your GYN. So the dilator is important, and important to talk to your doctor about if you have questions. Small bowel obstructions. The biggest thing about small bowel obstructions is dietary changes. You really have to kind of trial and error and see what bothers you, and really chew your food. Most people are in such a rush, they don't always do that. For the hematuria, the other thing that they might do for that is steroids to kind of help clear that up, and it just decreases the inflammation, so it'll take care of the blood in your urine. Sexual dysfunction, for GYN and rectal patients that are women, that scar tissue can cause painful intercourse. So that's another reason to, if your doctor's got you using a dilator, and use it as directed. And I just want to stress that it's really important to talk to your doctor. If you're feeling embarrassed about one of the side effects or the symptoms you're having, talk to the nurse, talk to the oncology navigator, let somebody know, because you don't want it to continue and then it's more difficult to treat.
Thank you, Terry. Great information. Our last speaker today is Lisa Sherman. Lisa is a certified breast care nurse, and she is a navigator at Kennestone Hospital, and her focus is seeing GYN oncology as well as breast cancer patients, but she has a wealth of experience in cancer and post-treatment care.
Good morning. Thank you, Barb. I'm going to talk about surgery and hormonal therapy and potential side effects from those treatments. So surgery in cancer is used for several reasons: to prevent, diagnose, treat, and stage, and in some cases help relieve discomfort or problems related to cancer. Sometimes a patient can have one surgery to accomplish those goals, and in some cases there may be more than one surgery needed over time. So these side effects can be ones that develop in active treatment and persist after treatment's completed, and those are known as long-term side effects, or they can be ones that develop many years, months or years later, and those are late-term side effects. And whether or not how these side effects impact patients depends on a lot of factors, including the original diagnosis, what treatment the patient had, and the patient's age. So I'm going to look at a couple different types of cancers and some of those side effects that might happen from the surgeries needed for those cancers. So in breast cancer, the surgery can include either a lumpectomy, where the tumor is removed, or a mastectomy, where the breast tissue, the entire breast tissue is removed. So of these side effects listed here, the limited range of motion in the shoulder and the numbness, tingling, and pain in the chest wall are ones that can show up pretty quickly after surgery and persist for some time. Lymphedema is one that may show up later, be considered a late effect, and that's a chronic swelling that can happen in the arm on that affected side. Risk for lymphedema depends on how many lymph nodes are removed. And then again, adding radiation, as Terry talked about, that may also increase a patient's risk for lymphedema to appear later on down the road. A study by the National Cancer Institute for a patient who had a sentinel node lymph biopsy, 5 to 17% of those patients developed lymphedema as a late-term effect. And then patients who had an axillary lymph node dissection, they're about 20 to 35% of those patients were seen to develop lymphedema. And that's just monitoring that arm on that affected side for any changes. Terry kind of touched on that too, about feeling anything different in that arm, it getting heavier, your jewelry not fitting well. Those types of things are things to bring up to your physician. For colon surgery, that surgery usually involves the removing the disease part of the colon. So you see some effects that can happen pretty much after, right after surgery and persist for some time, and that be the changes in bowel habits, an incisional hernia or gas and bloating. In some cases, many cases, patients who have surgery for colon cancer, an ostomy is created, and an ostomy is where there's an opening made on the abdominal wall for stool to come out there into a pouch. It allows for the rest of the colon and the rectal area to heal after surgery. In a lot of cases, that ostomy is reversed, and about 1% of patients do end up with a permanent colostomy. So the only true really late effect, something that could happen down the road to keep an eye on and think about, is a bowel obstruction due to that surgery and adhesions that can form in the colon. Looking at prostate cancer, again, prostate cancer, the surgery is typically a radial prostatectomy, which means the prostate gland is removed as well as some tissue around the prostate gland. These two, urinary incontinence and erectile dysfunction, are usually considered to be long-term effects. They start, you may see them, patients may see them right after surgery, and they may persist for some time. Usually urinary incontinence is something seen in generally older patients, but there's really no way to predict if a patient's going to have urinary incontinence after prostate surgery. And erectile dysfunction is something that depends on whether the nerves around the prostate are removed during surgery. Surgeons are, there is a nerve sparing prostatectomy that is available to prevent that side effect from happening. So the one thing to look for later years after being treated for prostate cancer is really just whether there's any disease progression. So that's where it's very important to do those follow-up appointments that have been talked about, and the healthy behaviors, taking care of yourself and keeping an eye on things and letting your doctor follow up with your doctor. For head and neck cancers, those surgery usually involved some cancers that appear in the voice box, throat, mouth, nose, and salivary glands. So the surgery itself depends on, or how extensive that surgery is, depends on the size of the tumor and then its location. And in some of those surgeries, it can involve a neck dissection that removes affected lymph nodes. So most of these side effects listed here are ones that happen, right after surgery and persist for some time. Late term, ones that may show up later, would be lymphedema, that chronic swelling due to lymph nodes being removed, neuropathy, and then a pinched nerve in the neck, which can cause numbness, pain, and weakness that radiates down to the chest and arm. And I do have to say, some of these head and neck patients may have additional surgeries, not just surgeries to remove the cancer, but surgeries that may help save or restore body function. For instance, to help breathing, they may have a tracheostomy surgery, or to help with nutrition, they may have feeding tubes replaced. So there may be potential of side effects that come from those surgeries. And then to help with these surgical side effects, physical therapy can help quite a bit. Obviously, the mobility movement issues, the lymphedema, again, as Terry has touched on, we have lymphedema specialists who can work in removing that extra fluid. Urinary incontinence and sexual dysfunction, the pelvic floor therapy, again, as Terry has mentioned, has been very helpful with that. And then there are medications that can help with the side effects of pain, bowel issues, erectile dysfunction, and any oral health issues. So talking about hormonal therapy, some cancers do depend on hormones to grow. And so the therapy itself blocks or alters how those hormones can help, alters those hormones can help slow or stop the growth of those cancers. And we'll look at breast and prostate, because those are two cancers where hormonal therapy is used quite a bit. So those medications for breast cancer patients, it's also known as endocrine therapy. There are two different types of hormonal therapy used for breast cancer. One is selective estrogen receptor modulators. SERM is that category of medicines, and the others are called aromatase inhibitors. So these side effects listed here are different based on which medicine a patient takes, which of those two types. So for the most part, some of these side effects can come on pretty soon after starting those medications. The ones to look for down the road would be the increased risk of bone thinning or osteoporosis, as we talked about, increased risk of stroke, and increased risk of endometrial cancer. Again, it comes down to following up with your physicians and just being aware of the fact that some of those may happen, and notifying your doctor of any symptoms that make you think you might be, one of those symptoms may be occurring. For prostate cancer, that hormonal therapy is known as androgen suppression therapy. And a lot of these side effects do again start and can be seen pretty soon after starting that medication. But ones to watch for down the road would be loss of muscle mass, bone thinning, cardiovascular disease, and diabetes. So managing those side effects, medications again can be used for quite a few of those side effects. For hot flashes, vaginal dryness, the loss of libido, erectile dysfunction, and then healthy behaviors can take care of quite a few. The cardiovascular disease, diabetes, again, bone thinning with doing weight-bearing exercises, and fatigue, which seems to be a common theme in any treatment for cancer, that exercise can really be helpful in that. So I'm also going to look at from these treatments, sometimes there's some effects on a patient's mental well-being based on those side effects. So surgeries for breast, colon, and head and neck can cause body image disturbance, and then surgeries and treatment for prostate and breast also can cause infertility issues. And then for breast and prostate patients, surgery or hormonal therapy can cause sexual dysfunction. So there is help. There are people to help with those. Mental health professionals, support groups, fertility specialists, and sex therapists are professionals that are there, people that are there to help with any of those issues. So that concludes my portion of this, and I will turn this back over to Barb.
Thanks, Lisa. We do have an opportunity for questions. If you'd like to write any in the chat room, our assistants will let us know if there are any questions in there. In the meantime, I just wanted to remind everyone that there will be a short survey sent to you via your email, asking you if you found this helpful, and if you would give us a little bit of feedback on how we might provide better or different information to you. We do hope these seminars have been interesting and helpful to you. And we would like to let you know that if you were not able to attend all 3 parts of the Rise and Shine series, they have been recorded and they will be posted on the WellStar website sometime in mid-October. So you can access one or all 3 of them. Thank you for participating. And I'll just ask Christian if there are any questions in the chat. All right. You have a way to contact us. Jess, you have Jesse's email and she works with each of us. So if you didn't catch our emails or our names, you're welcome to contact Jessie and she can forward the question or put the contact with the professional. Thank you very much. That concludes our seminar series, Rise and Shine.